And I think we're going to listen first about the presentation, and then we go from there. Comment, and if there's any questions, we can answer the questions. First, we will just limit it to focus what has been presented to us, and then we're going to make comment. If everybody has a question, we're going to try to answer as much we can. And I think, Jibril, you can start with us your presentation, and we are listening. And after you're done, we're going to see what comes about. We're going to open the floor for discussion, and we go from there. Okay.
Thank you very much, Dr. Chama, for the kind introductions. Here I am presenting with my dear colleague Artin Mahdanian, and the talk will be on consultational bias in psychiatry in the primary care and also in the hospital, where it's like general or specialist setting. And for me, my introduction is kind of brief and short. As you know, I'm from Burma. That's where I did medical school. And before going into being like a GP, before I went to psychiatry, I was just hanging around, doing mainly clinical practice as a general physician. But most of my general practice years, I spent in psychiatry. And also I was mainly doing a lot of global health work. Then I had to travel to Germany. That's where I did my public health training. And as Martin spent time as a WHO, intern in both in Cairo and Geneva. And then also I had to go around and join MSF. And I have been doing a lot of public health work, mainly public health epidemiology with Médecins Sans Frontières. And then I have some time doing internships mainly on medical editing. And now I am into psychiatry residency. The objectives of the webinar is just to describe the role of psychiatry in general hospital. What are the knowledge that we need to know when we are approaching psychiatry patients in the general practice? Then we shall be sharing how consultation psychiatry works with other medical specialties. And then we shall discuss the interplay between physical and mental health disorders. This will be mainly led by Artin, and demonstrate role of psychiatry practice in primary care. Our outline is just straight and forward. We shall be introducing CL psychiatry. We shall explain what CL psychiatry is and how it interacts with both physical and mental health disorders. We shall talk about mental health in primary care, and then we shall be taking your questions. Then can any one of you list your medical specialties here, like in the chat? Where do you come from? Do you like general practice, surgery, psychiatry, pediatricians? Then this can enroll the discussion a little bit. Can anybody just list what their specialties are? Medical intern, foundation year, and the likes. Then it helps me and Artin to understand our group dynamics here. As you are doing, I would like to just throw the ball to you now and ask you when a psychiatrist is needed in consultation of patients having mental health disorders. When do you need psychiatrists? Is there a time that you need a psychiatrist? Have you ever needed a psychiatrist to come to you and see some of your patients? Did that happen anyway? A medical intern, we have infectious disease. Yeah. For example, in infectious disease practice, in general practice, did any one of you needed a psychiatry consult? This occurs very often in medical clinical settings. And yes, can you go ahead the case you had in your practice? Dr. Musa, can you have also express, okay, Abshir Channel surgery, great. Can we have an example? This can be like a case study for you guys. Any volunteer before we start the lecture? Okay.
Could I speak?
Yes, please.
Thank you very much. I'm Saeed Mohammed from Turkey. I'm medical intern in Health Science University in Istanbul. And I'm interested in psychiatry because my mother was schizophrenia, and I think she was diagnosed when I was very little, maybe 5 years old. And up to now, she's using antipsychotics. And that is the part psychiatry involved in my life. And up to date, I was needed to consult psychiatrist, and I think the last time it was the Dr. Jabril who helped me very well. Thank you very much.
Yeah, that's like a life story, and usually this might come in, and I will show you even some practice from our hospital. Let's proceed. CL psychiatry, what is it? It refers to the skills and the knowledge utilized in evaluating and treating emotional and behavioral problems in patients who are in either medical or surgical settings. And this can be wide-ranging issues. It can be psychiatric disorders, it can be medical conditions that can manifest with emotional and behavioral problems, or it can result from a medical illness. It can be direct, or it can be a reaction to treatment, like a medication side effect or withdrawal or from a substance, things like that. It can be wide-ranging. And then another name that we use for some consultation liaison psychiatry is the psychosomatic medicine. And this is a subspecialty that sees the interaction between psychiatry and general medicine. And people usually go into CL fellowship after they complete their full psychiatry residency training. Like Artin here, he's a CL psychiatrist. The role of CL psychiatrist is to see patients who are both having psychiatric disorders and also medical problems. And this means that they address both their mental health issues and their physical health issues. It's a like holistic approach to treatment. And to this extent, it meets the definition of health by WHO. Who remembers the WHO definition of health? Because it is very holistic, addressing the issues of physical health and mental health together. Do anybody remember the definition of health by WHO? That famous 1948 definition. The definition says health is a full state of having physical, mental health with the absence of other adversities. And it clearly defines that health as health is not only physical health, and it also clearly addresses mental health issues at the same time. This is a very strong definition for health. This is what consultation liaison psychiatry does. It addresses the issues between mind and soul, mind and body, and it addresses that in a holistic approach. Historically, it was not prioritized, but now it is like a strong field within our practice of psychiatry. What the CL psychiatrists do for the medical patients, usually they do consultations, or sometimes they get referrals. Their role is very strong in terms of education, advocacy, and also contribute to the clinical needs of patients in wide range of services, not only in hospital, but also in the community. And here in many hospitals, I chose this because people don't put psychiatry when we are talking about different specialties in medicine. I think psychiatry should be like the first or the second. And if we are fair, according to the global pattern of disease, one of the leading contributors of morbidity, mortality, and disability are mainly today mental health disorders. Like the top 10, we have at least 4 or 5 are mental health disorders or substance use disorders or neurological disorders. Then today, not considering psychiatry can be a bit of difficult. I would like to share this case vignette and let us think through what this case can be. And this is a patient who says, I don't really know what the problem is, but the nurse seemed to be upset by this patient. The patient has just an MI, but it's doing well. This is what the nurse is saying. I think he may be a little depressed because he's so quiet. This is the observation of the nurse. When the consultant spoke with the staff nurse, the nurse had written that the patient was observed crying in the middle of the night. Upon interview by a psychiatrist, the consultant was able to diagnose a recurrent major depression in a patient who had just went through an MI. What do you think about this case? Is it a common thing that you see in your practice, for example, internal medicine, cardiology, and so on? It's just, this is an observation by a nurse, basically, that raised this discussion. I think what we do is that patients have also their own presentations and their emotional things, and observing them and seeing any change, any new change might warrant a psychiatry assessment. And it's very important that we observe our patients when they are in the OPD, when they are admitted, wherever they are admitted, and then we pick up their psychological signs and symptoms. Is there any case that you have met in your medical practice? Have you seen a patient who might have needed a mental health consult in your medical practice? And if you have seen, what did you do? And did you feel outpatient and different sorts of inpatients also need a psychiatric opinion in case of holistic care for your patients? Is there anything that you have seen in your practice? I will share, this is what I have seen in my practice. For example, this is where I do my psychiatry residency is a tertiary hospital.
Yeah.
Yeah, Ubah says, I doubt that our nurses can do such observation. I have never seen in my short experience, yeah? Ubah, can you go ahead and share your opinion?
Assalamu alaikum. Good evening to you all. And thank you so much, Jibril, for showing us these cases as an example. But my observation was I never had any nurse do such observation. I used to work with them for 8 months in the biggest referral maternal and child hospital. I never saw a midwife or nurse who refer us that some mothers, they saw them crying or not accepting well their newborns. What usually happen in Italy, where I come from, and I think otherwise in other countries also, I've never had such observation from our midwiferys or nurses over. But from my experience as pediatrician, I will absolutely call a psychiatric consultant to see and do proper diagnostic for this patient. Over. Thanks a lot.
Thank you, Ubah. Any other observation, experience with a patient having mental health issues? You can just go ahead and just share your comments. Okay, and this is from my hospital here in Addis Ababa. And our hospital is basically a tertiary hospital. What we do is that in the whole other subspecialties and specialist services we have, we have all this consultation liaison service between Department of Psychiatry and other branches of medicine. And if they see any resident or consultant or a nurse, any patient they deem to have any psychological disturbances, they just write their consultation form and they communicate back. This one is from internal medicine, and this was someone who had lymphoma, and he started his chemotherapy. What the nurses observed was that there was a change in his behavior, mainly in the night, which is characterized by confusion, irritability, sleep-wake disturbance, and seeing things that the others cannot see. And then they ask the Department of Psychiatry, this is our patient, this is the age, this is the diagnosis, this is what they take, this is the new changes they have seen, this is what we are doing, this is the physical exam findings, can you come and see our patient? This is what they requested. I just removed the name and date, all the things like that. And this one has been requested by the internal medicine like last week. Then because I'm the senior resident, the junior resident have to consult me what to do with such a patient. And this is another woman. This is what Oba was talking about. This is a postpartum period, a woman who just delivered. This lady was a known schizophrenic patient. And then when she delivered 1 day later, she had a relapse actually. And they are asking the Department of Psychiatry to come and assess her and work together on the discharge plan together to link her up to our outpatient services. This is what a consultation does usually. I would like to take you to the history, psychiatry in your patients. There are a lot of psychiatric problems that have been in medical patients. George Engel coined the word the biopsychosocial model that we use in psychiatry, usually in our own formulations, when we address the biological causes, the social causes, the psychological causes of mental illness, and we go through the risk factors, what precipitates this, what perpetuates this, what protects them, and what predisposes them. As you see, as you shall see in the next slide, he was actually, George Engel was an internal medicine specialist, but he had a strong interest in psychosomatic medicine. That was in 1978, 1979, where he coined the word biopsychosocial model. And actually, this is what we use in our psychiatry formulations, which inform our psychiatric management models later on when we are managing patients. And as you see, when we are dealing with the typical psychiatric patients, we don't only treat their psychological issues or their social issues, we also address their biological vulnerability, precipitative factors, perpetuative factors, and protective factors. And you see, within psychiatry, we also have a strong interest addressing their biological needs. Because if you don't see the patient from a holistic point of view, we may be missing points in our clinical management in the immediate, short-term, and long-term plans through our biological interventions or psychological interventions or social interventions. And psychiatric patients are not having only psychosocial disturbances, they may have medical conditions. And if we don't fail to address these, patients tend to be undertreated. That's why we always check our formulations very strongly as a part of our assessment of patients in general. And some people call CL psychiatrists as biopsychosocial psychiatrists, but in every psychiatry we do that. And this is what we do basically when we see patients in the consultation liaison psychiatry. These are the things that we usually do. We try to talk to the referring physician in detail to know what led to this consultation. That's what we need. If we don't do that, it will be very serious because we could not be able to know what's going on. It's like we don't simply act on these papers only. We also talk to you guys. We confirm the primary team, who they are. We review the medical records. We collect any possible information that we can get, and then we document it. At the same time, when we come to your settings, we also look at the biological issues, psychological issues, social issues. And in the consultation, these the layers we do. We have to collect any potential information. And you find us to doing all the things that you have been doing. Our job is to make sure that we review everything carefully, to give you a very precise, concise advice on what you have to do. And we are a bit thorough when we do consultation liaison for you guys. And this is what we do actually. We speak to you as a consultee, we review your records, basically everything. Sometimes we just find that patients, for example, in delirium, the patient's problems may be aligned with the medical management, for example. I had a patient whom the surgery residency asking me to see as a resident who was doing CL psychiatry in my CL rotation. The patient had alcohol withdrawal, and no one asked him if he had alcohol withdrawal in his symptoms. His delirium was actually an alcohol withdrawal delirium. And then we had to collect the alcohol withdrawal delirium. And another patient had simply electrolyte imbalance, hyponatremia. And then we had to simply collect that. And that's very important that we review the record. We review the medications. Some medications might trigger a psychotic episode. I remember this lady who had Cushing syndrome, and she was on steroids, and then she jumped into full-blown psychosis, and then actually lowering down her steroids helped her a lot. And things like that. Medications are very important. Gather information from family and others. We do a lot of collateral histories. We interview the patients, we do mental state exam, we conduct physical exam and neurological exam, because this is extremely, extremely important. For example, in Ethiopia, many patients who are simply confused are people who are having working rickets encephalopathy. We had a lot of them. For example, if I don't do a thorough neuro exam, I could miss that easily. Then we write the note, and then we talk to you as a consultee to give you a thorough feedback. And when we are writing the note, we try to be very concise, to the point, and just tell you the core things that you have to just follow. The nature of psychiatric consult. Why is a psychiatric consult generated? It's generated because you see something that's abnormal and you just want us to help out. You might ask us our expert opinion. It can be a patient's request. It can be a discomfort by you guys seeing your hard to treat or difficult patients sometimes. This can be something that can trigger you to ask a psychiatric consult. As a CL, we determine the focus of the consultation, what it is, the comprehensive assessment, if it is needed, and if there's management issues, emergency issues like agitation, we manage. And then I invite everybody of you just to read this paper. It discusses on why CL is important and what psychosomatic medicine contributes to medical practice. Although an old paper, but it expresses the benefits like preventing poor quality of services, improving the quality of care of patients, improving the overall improvement of patients. These are some of them. And this is what we always do. This is a repetition of the last slide. And this is what we do in the mental state examination. And then we go through holistically. And these are the reasons why we do consultation liaison in psychiatry. You may ask us because of mental illness issues like depression, anxiety, psychosis, or you may ask them because they are simply difficult cases, or may have general medical condition that may contribute to a psychiatric manifestation. And these are the differential diagnoses that we make in consultation psychiatry. Psychiatric presentations of medical conditions, like medical conditions leading to psychiatric conditions, a psychiatric complication of a medical condition or treatment, psychological reaction to medical condition, like distress, medical presentations of psychiatric conditions, and the issue of comorbidity, independent comorbidity between a physical illness and a mental illness. In this case, Phineas was discussing a difficult case of a psychosis induced by SLE. In El Salvador, we have a lot of them, like SLE, Cushing, HIV, and so on and so forth. Some of them can be easily missed. And because of infectious disease that may not be relevant now in America, things like Stedham, Korea, and others, we see a lot of medical issues here. Special populations we need to consider are the geriatric populations, emergency setting, inpatient and outpatient setting. Don't forget community. For psychiatrists, addiction and forensic services, child and adolescent mental health services, and also issues related to psychodynamics between patients and families and all these things, which might look like sometimes as a psychiatric issues, but might not be a psychiatric issue, just understanding the psychodynamic nature of presentations. For example, this is the American Academy of Child and Adolescent Psychiatry. They had these parameters developed in 2019 for child and adolescent psychiatry consultations, what we have to do and what we have not to do. For example, we understanding the family dynamics, understanding the child's illness, reasons and the purpose of these referrals, assessment which integrates development issues, physical issues, and with the reason to generate a well-structured biopsychosocial formulation, child medical conditions and how it should be addressed, psychopharmacological issues that we have to see, and so on and so forth, family issues, adherence issues, complementary alternative medicine, if it has a role, an issue of culture and religion. And now in DSM-5 TR, we have the cultural formulation interviews that we all do. And in terms of child and adult psychiatry consultations, this is very tricky, where that's where OBAH comes in. It's not only looking the ill child, but also looking the systems surrounding the child, whether they are microsystems, which is mainly the family and the child, and also mesosystems, which includes the nurses, the doctors, the teachers, the clerical schools, social workers, child protection services, and so on and so forth. And also exosystems, which include social work, employers, colleagues, workplace, and also the society, culture, religion, and everything in between. The reason is the child is not a single standing item only. The child's psychosocial and mental well-being is also affected by the other systems that surround the child, which include the school, the neighborhood, and the likes. And this is, as a consultation, like also psychiatrists, we look things even holistically beyond the biopsychosocial interventions. Then in special situations, the role of somatic symptom disorder, the resident patient, difficult and hateful patients, what do we do with these patients? Even this can irritate a psychiatrist at times and affect the patient-doctor relationship and the likes. For example, things that I would like to see is the issue, for example, pseudo engagement, things that may indicate your patient may be a difficult patient and the likes. For example, if the patient is like having a minimal response or doesn't want to talk to you and just gives you a categorical answer, yes or no, and if the history is very inconsistent, information from the collector and the patient are different, if the patient is hostile or irritable, or the things like that, that you may see some of your patients. If you see that, don't just dismiss them as simply difficult patients. They may need a psychiatry approach. Maybe they have personality issues and the likes. Or they may have secondary gain issues like malingering and so on and so forth. And the issue that I would like to raise that's very common in the general practice is the hateful, difficult patients, which are really interesting kind of patients. If you see the Groves category, the Kirchhoff category, how these patients are just difficult patients, understanding the approach is very important. Like if a patient is an entitlement demander, that's very common among Somali patients, sometimes in the private practice. Then things like avoiding confronting entitlement and identify obstacles to best care, you might be negotiating what would be the best care of patient. This may be an area that we might need to talk to a psychiatrist, where they could do, psychologically informed interview, and they interview the patients and the psychological needs. But these patients can quite irritate you, like the dependent clinger, the manipulated self-rejecter, and self-destructive denier. These are some of the difficult patients that you may see in a typical clinical practice. And if you see them, it's good to consult psychiatry. And privileges and duties, this is where ethics comes in. Like, what's the best interest of the patient and what we can do? Even in a difficult situation, considering and nurturing ethical values is also important, and we don't need to forget that. As I said, ethical issues are very important in any interventions, particularly in consultation psychiatry and any encounter with patients. And normally, what we do is that we understand patient's situation before we do. We consider issues related to autonomy, for example, and the likes. It's also an important issue if you see patients who also need forensic psychiatry issues. This is a case vignette I saw in my second year psychiatry residency. This is a Master A. He was a prisoner. He was in the jail. He was serving a life sentence. The patient was admitted to the general acute psychiatry unit for forensic gangrene. The general psychiatry rotation asked us to do a consultation because this guy was coming back to the surgery service for several times, 4 or 5 times, and all the time he was presented was forensic gangrene, and they were suspecting maybe this person was causing self-injury to afford prison terms and stuff like that. Actually, they requested a psychiatry consult. This was extremely challenging patients. And by the end of the day, it was clear that the patient was doing self-injury to induce this massive injury to himself. And he had clear secondary gain, but the reason was not also to deny the right he had to get, services and the likes. Yeah, this guy was very disturbing for the surgical ward and everybody else. And they had to request the consultation anyway. CL in primary care is becoming, in the last decades, is strongly relevant, that also in primary care as the gatekeeper of mental health services, CL has a strong role, like training of primary care staff on when they have to consult psychiatry still is also strongly relevant. This is where consultation liaison comes in, giving brief assessments of patients, and also training and informing primary care professionals about management, like evidence-based management. And then there's a strong possibility of collaborative care between primary care and psychiatry. And all this aims to help those guys doing primary care to address the mental health needs of their patients. By the end of the day, this increases the involvement of primary care in decision-making and helping patients, and also increases the involvement of mental health professionals. And in many countries, that's where even where there's no psychiatrist, image gap and others also address issues related to primary care in CL. And this is what happens. Inpatient flow to outpatient flow. For example, inpatient flow, you ask us to do a request, we come in, we triage, we assess your patient, and then we give you feedback. And then we assess the patient, we give the treatment. In the outpatient, you request, we do the triage, we assess your patients, the same thing. Now, and that will be my part. I will leave the questions for at the end, but now I have to welcome Artin. Artin, floor is yours.
Okay, thank you, Dr. Jibril. Thank you for the organizer to inviting me to this presentation. Jibril made, I think, everything clear about CL psychiatry, so I don't have a lot more to introduce. I thought maybe it's not a bad idea that I start with presenting myself. Artem Madanian, I'm an Iranian-Canadian psychiatrist, currently based in Johns Hopkins at Maryland. And I work in CL psychiatry consultation liaison in the suburban hospital of Johns Hopkins. So background-wise, as you see a lot of similarities between me and Jibril, I worked in primary care after graduation from medical school, and in a rural area between Iran and Pakistan. So that was the time I got mostly interested in CL psychiatry, because I saw a lot of patients with somatic disorders without medical explanations of the somatic disorders. And that's why I thought, okay, this is the area I'm interested in. I got into doing a master's in psychosomatic research, side effects, bleeding side effects of antidepressants, and then my psychiatric residency. When I was time to do the fellowship, I was looking about where I can do a subspecialty fellowship. US, European countries, they have subspecialty, so I chose US, closer to Canada, and I did my CL fellowship. Now, next slide. Dr. Jibril talked about all the basics of psychosomatics: psyche, mind, somatic, body. That's why the interaction between mind, body. I don't want to go into the philosophical definition of mind-body interactions, the duality or unity of mind-body, but there is a strong interaction. Whether we consider from a neuroscientific point of view that mind and body, they are the same thing, and the same neurological processes that happen in neurological disorders happen in mental health conditions, or we consider them separate entities, they interact to each other. So healthy mind can, kind of produce a healthy body. Biopsychosocial model, Jibril explained, nailed it. I just would like to add that I always say biopsychosocial, etc. model, because there's a lot more than biopsychosocial. There's the cultural aspect, there's the human rights aspect, and a lot of spiritual aspect that needs to be considered. And I always, when I'm seeing a patient in a hospital setting, a specialty, as Jibril said, CL psychiatrists are known as biopsychosocial psychiatrists. I see my patient biopsychosocially, I formulate them biopsychosocially, I diagnose them biopsychosocially, and finally, I make my recommendations and plans biopsychosocially. So this is very important, that when you are seeing a patient in general hospital settings or primary care, you consider all aspects of the patient in your diagnosis and treatment. Now, psychosomatic medicine definition, it can be considered from the research aspect, internal medicine, infectious disease, they all have aspects of psyche into the condition, and biopsychosocial aspects, holistic view of patient in another thing, and subspecial types of psychiatry is another aspect of biopsychosocial model. Next slide. So the clients, I think, kind of, Dr. Jibril explained before that there are three main clients that we see in hospital settings: patients with a medical condition that they have a comorbid psychiatric conditions, patients with somatoform functional disorders, disorders that they don't have any medically explained conditions, and the last resort is to ask the psychiatrist, is it because they are depressed or anxious? And patients with the psychiatric conditions that is direct consequence of the medical conditions, as we explained, delirium, HIV, dementia, or we can say psychosis due to medication or due to brain tumors. They are directly related to the medical condition. Next slide. And so in psychosomatic medicine, we make some assumptions as soon as you go to see the patients. First of all, you see the assumption of the unity or a strong interaction, if you believe in duality, that mind and body, they are very much interconnected, and you should consider both of them at the same time. That's why CL psychiatrists, they should have very good knowledge of internal medicine. They should have very good knowledge of surgery, not to the expert level, but at least to the intern level or PGY1 resident level, know everything. There are a lot of opportunities that as a CL psychiatrist, you should advocate for your patients for their medical treatment. There's unfortunately still a stigma for mental health in different settings, even in developed countries and the highest ranked universities and hospitals in the world, you see the stigma against mental health. So as a CL psychiatrist, when you see a patient, you should be advocate of the patient. As soon as they see the diagnosis of a schizophrenia or bipolar disorder in patient's chart, they try to say that, oh, psychiatric patient, so there's nothing medical to be done. So a CL psychiatrist should be able to check the records, find if there's any medical thing going on, if there's any aspect of medical or surgical management that needs to be done at the same time of taking care of the mental health of the patient. The second most important thing is all psychological factors of the patients must be considered when they are in a medical floor. So the surgeon usually objectively looks at what needs to be done as a surgeon, but then they don't usually have time, or they don't usually look into other aspects. Is this patient homeless? Do they have job? Where are they going to do after the surgery? What are they going to do with the substance use disorder that they have? They have grief disorder, depression, a lot of psychological thing going on. The surgeon takes care of the appendicitis of the patient, but then it needs a team of CL psychiatrists, maybe social worker, to take care of the psychological factors. And the holistic approach we talked about. So I say biopsychosocial, you see a lot of times it comes up in the CL psychiatry. Next slide. So briefly, I want to talk about somatoform disorders. I can say maybe once. The hospital I work in is a community hospital in a suburban of Washington, D.C., about 200 beds. I see 1 or 2 consults of somatoform disorders in a month. And it's usually patients with pseudo seizures, conversion disorder, or somatic symptom disorder, pain, mainly pain specific. So it's usually medically unexplained symptoms. It used to be as if patients with somatoform disorder, they don't have any medical symptoms, but now we believe that they really have the symptoms. They really feel, if they say, I have pain, they have pain. If they complain of paralysis or seizure, they have those events. So it's not that they fake it or they don't have it, but there's no medical explanation for those symptoms. So in DSM-5, the diagnoses are somatic symptom disorder, which is mainly focusing on the symptom. So there is a symptom and the symptom is medically unexplained. The patient focuses on the symptom, the behavior, the emotions, and the anxiety related to the symptoms are excessive to the level that disrupts the function of the patient. Usually the patient's doctor sick, they go from this doctor to that doctor and no treatment helps. Illness anxiety disorder, on the other hand, the symptom is not that prominent. So the patient usually has the worry and anxiety of having a medical condition. So there's no much of a symptom of pain or paralysis or any other symptoms. There's more the worry and anxiety. Conversion disorder, usually the main thing is a neurological symptom like paralysis, seizure, loss of consciousness, but there is no medically explained or neurologically explained for that. And factitious disorder, it's usually an unconscious production of symptoms for a secondary gain. So I have had maybe 2 or 3 factitious disorder consults in the past 1 year, and it's very difficult to make the diagnosis, to make sure that it's, the patient is actually producing the symptoms for a secondary gain, and a secondary gain is unconscious. But you can always consider it when there is unexplained medical symptoms and there is evidence that there is a secondary gain and the patient might have inflicted the symptoms. Next slide. So before coming to medicine and psychiatry, for somatoform disorders, in terms of what a CL psychiatrist can do is mostly providing support to the team, because usually, you know, as a CL psychiatrist, you are not only dealing with patients, you are dealing with a medical team, the medical specialists, the nurses, and the patient. So on one hand, you act as a supportive therapist or the medical specialist for the patient. On the other hand, you also work with the team to help the team to deal with the patient. Somatoform disorder patients usually are patients that are very difficult. They doctor shop. It's difficult to discharge them, difficult to tell them that, you know, all the tests are negative and there's nothing else to be done. So usually you help the medical team in the liaison with the patient. So that's in communicating with the patient. So that's when the communication skills of a CL psychiatrist come in handy. And then referral to the outpatient for the follow-ups. Now, the interaction of medicine and psychiatry, Dr. Jibril explained some examples. I'm going into a little bit of more details into different medical specialties that you can be consulted for patients. So in neurology ward or neuropsychiatry aspect of CL psychiatry, you can have patients with CVA and a stroke that they present with the complications of CVA. In terms of mental health, it can be depression. Depression has a high correlation with CVA. We used to think that right side CVA, left side CVA is different in the kind of prevalence of depression, but now we know that it's similar on both sides. And then is it hemorrhagic stroke or it's a ischemic stroke? Why is it important in terms of your treatment? We know that some of antidepressant treatments can predispose bleeding in the patients because of platelet aggregation problems. So if a patient has hemorrhagic stroke in the past 6 months and depression, then in terms of choosing the medication, we consider that what medication should we give not to predispose the patient to further bleeding. Epilepsy, again, a lot of comorbidities of mental health, depression, anxiety, psychotic disorders. But there's one thing important to know that post-ictal period, patients can present with a lot of psychiatric symptoms that is not a psychiatric diagnosis. So you might be consulted on a patient post-ictal, they say the patient is depressed, withdrawn, or having hallucination, delusions, paranoid ideas. But this is in fact post-ictal period, and post-ictal in patients can vary. Sometimes in some patients, the post-ictal can last hours and days. So this is something to consider. Multiple sclerosis, it's very comorbid with depression, not only because of the difficulty in functioning and the psychological aspect, but also the biological aspect of it. And also the treatment of multiple sclerosis, for example, interferon, can predispose patients to further depression. Parkinson's disease, usually in the end stages of Parkinson's, they have dementia, they can have depression. And then again, Parkinson's disease, when they have dementia, behavioral disturbances, or psychotic symptoms, a lot of antipsychotic medications, some of antidepressant medication may worsen the movement disorder in Parkinson's disease. So when you are prescribing medication, you should know the Parkinson's disease and which medications, for example, in antipsychotics, quetiapine or clozapine are the medications that are less problematic in movement disorder of Parkinson's disease. Dementia, it's the bread and butter of CL psychiatry these days, especially behavioral aspect and behavioral and psychological aspect of dementia. Aggression management, you get a lot of consults. I can say that in that area, you know, another aspect that we forgot to mention, one of the roles of a CL psychiatrist is teaching and training medical specialists. So I do a lot of teaching to internists, hospitalists, and emergency doctors about management of aggression in dementia patients. So they don't need necessarily to consult a psychiatrist, but they need a lot of support in terms of management and medications. Geriatric population, end of life care, delirium, another bread and butter of psychiatry. You get a lot of, in the area of delirium, I would like to mention another thing, and that is when you get a consult in psychiatry, it's very important to know what exactly the question is. And always remember, the question is not necessarily the answer. So you may get a question, patient is depressed, withdrawn. You go and evaluate the patient has hypoactive delirium, is not participating in activities, is sleepy all through the day, and they take the patient as depressed, but this is mainly hypoactive delirium. So in delirium, you get patient is anxious, patient is hallucinating, patient is paranoid, psychotic, but it's in fact hypoactive delirium or hyperactive delirium. Demolarization, another area that you get a lot of consults in psychiatry and in the name of depression, that patients with end-of-life care, severe cancer, metastatic cancer, you are consulted for depression, but that's in fact not depression. A lot of symptoms of depression are the same as symptoms of cancer and end-stage cancer diseases, like lack of appetite, difficulty in sleeping, low energy, low concentration. So if you want to count the symptoms, you might be able to count 5 or 6, but in fact, it's more demolarization. The patient doesn't have guilt, the patient doesn't have anhedonia, but it's a realistic depression of an end of life. So again, you want to care with supportive therapy, medication, or helping, supporting the team in terms of diagnosis. Medical assisted in dying, it's an area that in some countries they consult psychiatry. In Canada, it is something approved. Capacity assessment, another area that is bread and butter of psychiatry. I think 1 consult per day. Patient refuses a treatment, and then the medical team, they want to assess capacity, they ask psychiatry. We always have 4 elements to consider when we are assessing for capacity. It's if the patient understands the information, appreciates that the information apply and the consequences and the alternative options applies to them, they can sustain a choice, and they have a rational kind of reasoning that is not clouded by severe depression or psychosis. If the patient has these 4 elements, they are allowed to make bad judgments. So just remember, as a CL psychiatrist, if the patient is refusing a life-threatening treatment, it doesn't necessarily mean that they are incapable of making that decision. As long as they understand, they appreciate, they sustain their choice, and their logic is rational, they're capable of making whatever decision. So that's autonomy. Cardiopsychiatry, side effects of medications. We all know orthostatic hypotension happens in a lot of antidepressant medications. QTC interval elongations, antipsychotic medications, and antidepressant medications. So you might need to change the medication of patients. Depression after MI, anxiety in patients with cardiac conditions. I have had actually a friend who was being followed by psychiatry for 6 months for severe anxiety, and it turned out to be a very rare cardiac tumor that was the cause of anxiety. So after he had the surgery, the anxiety was completely gone. Hypertension, another area that when you're choosing your medication for depression and psychosis, you can consider. In terms of women mental health, premenstrual symptoms, premenstrual depressive disorder, and perinatal episodes of depression or psychosis, that's another area, or depression around menopause, another area that CL psychiatrists, they get called for a consult. It's a very big area to the point that it's a subspecialty by itself. So a lot of CL psychiatrists, they subspecialize in prenatal care, and they do consultations only for prenatal area. Psycho-oncology, cancer and depression, we talked about demoralization and about choice of medication. We should also consider there are some, for example, cancers that the first presentation is depression. For example, the colon cancer, it can present as first symptoms, depressive symptoms, and low decreased appetite and those kind of symptoms. But then the presentation of cancer itself might be later than the depressive presentation. Transplant psychiatry, that's another area that CL psychiatrists are consulted. Almost all transplant patients have a psychiatric consultation for the eligibility. And then substance use disorder, depression, if they are active to the point that the patient cannot take care of themselves after transplant, they are contraindications for the transplant. But it doesn't necessarily mean that the patient is ineligible for transplant, but the patient needs treatment of the comorbid condition before the transplant is done or is scheduled. So treatment of depression, treatment of substance use disorder are very important in transplant patients. And HIV psychiatry, we know a lot of comorbidity of mental health comorbidities in HIV patients. The depression, substance use disorder, and the stigma with the HIV that can consequently cause a lot of mental health symptoms are important things to consider. And HIV dementia also in advanced HIV patients is an important thing. Now, just summary of what Dr. Jibril talked and what I mentioned. Psychosomatic medicine is deeply rooted in biopsychosocial, etc. model. So consider all the aspects of the patient, a holistic approach of the patient. Be advocate of your patients when you see a patient with mental health conditions on medical floor. Act as patient's physician, not only the psychiatrist. So make sure that they get the medical treatment, surgical treatment that they need, regardless of the mental health condition. Biopsychosocial model is far easier said than done. It's difficult to consider all the aspects of the patient, but do your best, do as much as you can to look in the patient in biopsychosocial treatment and biopsychosocial formulation. So there also consider the cultural aspects of the patient. So in the US, I see a lot of patients from all around the world, and not all physicians are familiar with the cultures. Patient talks about something about that he has been voodooed, and the medical condition is because of a voodoo or because of a curse, and they consult psychiatry that the patient is psychotic. But then you talk with patient, you talk with the family, and you see that they are from a culture that they believe in voodoo and they believe in being cursed or an evil eye or bad eye. But the medical specialist wasn't that much familiar with that culture maybe at that moment, or didn't have the time to get into the depth of the comments that the patient makes. So consider cultural aspect and the socioeconomic of the patient. Psychiatric conditions are very prevalent, among medical surgical patients. I think one study showed up to 50% of patients admitted on medical floors, they have a comorbid psychiatric or personality disorder traits. So as we mentioned, try to use as much information as possible in consultations. Just see your patient, get collateral information, talk with the medical team, ask the nurses, ask the sitter, ask the security or the administrative agent, the operator or secretary of the unit about the patient. You get information sometimes that you are surprised. Sometimes the patient is walking, pacing in the unit, and only the security who is sitting at the door can tell you some information about this patient that helps you out. The patient maybe is akathisiac because of a psychiatric medication and is pacing all around the unit. And the patients in general medical hospital are challenging patients. So be patient, work with the team, be a team worker, and you will be fine. I think that's my last slide. Yeah, okay. So thank you so much for the listening. I'd be happy to answer any questions.